Good afternoon. Welcome to the launch of National Public Health Week 2019. The inaugural National Public Health Week actually was held in 1995, 24 years ago, with the theme of Public Health is You Too, which I think works very well for what we're going to be talking about this afternoon. It focused on the role that people can play in protecting their own health and that of their families and communities. A presidential proclamation noted that health is one of life's precious gifts. That's what I've always appreciated about National Public Health Week. It celebrates the contribution of public health workers, of grassroots advocates, of those in universities and communities, of students who are being educated to take on today's public health challenges. This afternoon, sorry, I didn't quite make that transition either, we will be engaged with grassroots advocates who are the backbone of public health communities, starting with a keynote address. But I'm going to just do one other thing before I introduce our keynote speaker, and that is to thank the Aetna Foundation for being here today and for partnering with us in this important work. Now, it's my privilege to introduce our keynote speaker, Joya Creer-Perry. She is the founder and president of the National Birth Equity Collaborative. Recently, she addressed the United Nations Office of the High Commissioner for Human Rights to urge a human rights framework to improve maternal mortality. Previously, she served as the executive director of the Birthing Project and director of the Women's and Children's Services at Jefferson Community Healthcare Center, and as the director of the clinical services for the City of New Orleans Health Department, where she was responsible for 4 facilities providing health care for the homeless, pediatric, WIC, and gynecological services. Dr. Creer-Perry continues to work to improve access and availability of affordable health care in New Orleans. After receiving her bachelor's education at Princeton University and Xavier University, Dr. Creer-Perry completed her medical education at Louisiana State University and her residency in obstetrics and gynecology at Tulane University. She is a fellow of the American College of Obstetrics and Gynecology. A proud recipient of the Congressional Black Caucus Healthcare Heroes Award and the Harvard University Global Visionary Award for commitment to advancing women's health, Dr. Creer-Perry currently serves on the advisory committee of the Black Mamas Matters Alliance, principal at Health Equity Cipher, and on the board of trustees for Community Catalyst, National Medical Association, and the New Orleans African American Museum. She is married to Dr. Andre Perry and has 3 children, Jade, Carlos, and Robeson. Her love is her family, health equity is her passion, and maternal child health are her callings. Please join me in welcoming Dr. Creer-Perry to the podium.
Thank you so much for that warm introduction. Good afternoon, everybody. I'm from New Orleans, so I'm a little loud, just have to say. So I will probably be a little bit louder. I'm going to try to not be too loud for you. I am so honored to be here. Thank you. I've been a member and a part of APHA for a while, so it's exciting for me to kick off this week and having this opportunity to have a National Public Health Week. I didn't realize it was 24 years old. I guess that's about your age, right, Jordan? I have to call out my godson, it's the thing we do. Yeah, so it's as old as Jordan, so it's going to make me always remember that, so thank you for that. So it's important for us to honor the grassroots and the movement, because that's the birth of really public health. It came from grassroots, and although now it's become this huge kind of bureaucracy and it's inside of academic structures and public health departments. What I hope we will get to today is, if you hear nothing else that I say today, to remember that the beginnings of public health started in the community, and so that's what we're going to have to really do to hold it accountable, to decolonize it, as we were talking about earlier, as we move forward. So as was mentioned, I'm the founder and president of the National Birth Equity Collaborative. When we were founded 4 years ago through funding through the W.K. Kellogg Foundation, we did not have a definition for birth equity. There were definitions for equity in general, for health equity, but not specifically for birth equity. So we sat as an organization and really thought, well, what does that mean for us? You know, you need to have kind of a North Star or a vision or a definition of your work. So we looked at all these other definitions, and what resonated for us, some of the definitions for equity speak of it as a place, right? We're going to get to this place where everybody's equal, we're all going to hold hands and sing Kumbaya, and the world will be wonderful. But we recognize, especially sometimes in our current political environment, that we can get a couple of steps forward and a few steps back, right? So perhaps we're not looking for a place of equity, but we're looking for the assurances. I do not expect my grandchildren to not have to keep fighting for equity, because there will always be people who want inequity. So what we have to be to do is make sure that we put the policies, the assurances, big P, little p, in place for equity. So that means we have to then look for the conditions for optimal birth. So we don't want people just to survive pregnancy and say, ooh, I made it, right? We want them to thrive. What does it look like to have your best life, your best pregnancy? And we have to be willing to address both racial and social inequalities in a sustained effort. So to my friend Garth Graham and others at Aetna Foundation, we love you for these grants, but it's going to take more than 3 years to fix this, right? We got here for 400 years we've been here, so it's going to take a long time to unpack some of the traumas that we've been through. I don't know if you've heard of reproductive justice. Anybody in the room heard of reproductive justice before? Yay, okay, good. So my RJ advocates, right now, a lot of them are at a birth summit together working on equity there. So reproductive justice was founded in the 1990s by Black women, and then women of color continue to build upon it, and we're still right now working on kind of reproductive justice 2.0, because frameworks and movements always evolve, right? But it's in original beginnings, it was a response to the first iteration of healthcare reform under the Clinton administration. So imagine at that time, we had this opportunity in the 90s to really expand on reproductive rights. So there's a lot of conversations about contraception, access to having abortion, all those kind of language. But what there wasn't a conversation around, if you are a Black woman, even though I can have access to contraception, if I'm worried about my 8-year-old son playing in a park with a toy gun, I don't have reproductive justice. So we really had to expand the lens around what really reproductive justice would look like. Black mothers are afraid that they won't outlive their children. So you need to be just as worried about my son if you want us to have reproductive justice, and not that I have access to a birth control pill or a LARC in today's environment. So the meaning of it, according to Loretta Ross, is that you have to maintain personal bodily autonomy. So that means, like, if I don't want a LARC, I don't want a LARC. You can't make me have an IUD if I don't want one. If I want to have children, so if I want 8 children, it is my choice, my body, you can't control that. And if I don't want to have children, I am a whole human being, regardless if I ever decide to have a child. I was valuable just at being. So we value right now a lot of women inside of our healthcare system only during pregnancy. So we only pay for their health care when they are pregnant. So that says that we don't value them in any other time in their life. So there's a lot of women who never have children. What are we saying about our value for them? And then lastly, and the part about my son in the park is really this idea of being able to parent your children in safe and sustainable communities. So that is really where you get into understanding things like mass incarceration impacts our reproductive health, right? Environmental justice impacts our reproductive health. So you cannot silo reproduction to only the issues around access to birth control if you're not worried about all these other intersecting ideas. So the work that we do really centers around both Black infant and maternal health, and part of the reason is back in 2010, Amnesty International and the UN sanctioned the U.S. around maternal mortality. They have a whole commission on the Committee for People of African Descent across the globe, and when they came to the U.S., they saw things like mass incarceration, they saw things like lack of education. What they saw for health was that we are the only industrialized nation where more mothers are dying in childbirth now than they were 20 years ago. That says that my daughter is more likely to die in childbirth than I was when I had her. So we are going backwards. Every other nation who has as much money as we do, their numbers are going down. And for Black women, that number is 3 to 4 times the rate. So we understood that when that information came out as Black women, as advocates, as people inside the reproductive justice movement, if we didn't get ahead of that narrative, talking about the fact that Black women were dying at 3 to 4 times the rate, what we would get back from media and from policymakers is, well, of course they're dying at 3 to 4 times the rate because they're more obese and they don't listen and they smoke and they're more obese. That's always we start with obesity and just keep going. So we really wanted to make sure that we have a narrative that understands the structures around that and not just problematizing individuals and behaviors. These are the common clinical indicators for maternal mortality, and you'll see that cardiac disease is the most common. At one point, it was hemorrhage. So what this slide is really to point out to you is that we have had a commitment from our medical community for the last 10 or 15 years to start focusing, and when we focus on a thing, we can do really well. So hemorrhage was number one, and we got hemorrhage down, but guess what's coming up now? Cardiac disease, right? And what is cardiac disease a sign of? A sign of people not having access to insurance before they get pregnant? A sign of them not having safe and sustainable communities? All the things I mentioned in the beginning around reproductive justice, you see come out when people have, like Erica Garner, dying from cardiomyopathy 6 months after having a baby, the stress of racism killing her body, right? So we have to really own how we are toxic to women's bodies, and that causes them to have higher rates of illness and disease. When we were able through work with the New York City, to disaggregate the data, right? Because if the narrative is the reason Black women die in childbirth is because there's something that they're just doing, we don't really have data to support that. So when we disaggregate the data by income, by weight, by neighborhood, these are the kind of things you find out. That Black mothers who are college educated fare worse than women of all races who never finished high school. That obese women of all races have better birth outcomes than Black women who are of normal weight. So I can't even crunchy my way up, right? I do my little yoga. That Black women in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poorest ones. We can't even move from it. And then this is the one that my OBGYN colleagues really struggle with because we believe we're saving the world and we're so awesome. African American women who initiated prenatal care in the first trimester had higher rates of infant mortality than non-Hispanic white women. So even that the narrative, when you pick policies just based upon these narratives, you're going to do things like we got to get everybody into prenatal care. And that won't still save us. That won't end the disparities and the inequities that we have because they're getting into care and they're being treated poorly and they're not being listened to and they don't want it. And then they end up dying in childbirth like many of the advocates that you'll see in some of the articles you might have read. So it's just important for us to, this framing, what it means is, yes, income is protective for Black women. Yes, education is protective, but it is not as protective as being white is, right? So whiteness, when we created this idea that there are difference of value for human beings based upon race, that comes out in our health outcomes. It's a made-up idea, but the good news is we can stop doing it. Okay. So some of the risk factors that are clinical risk factors, as if you come to the doctor's office and you say, I'm pregnant, and I heard this thing about people can die in childbirth and Black women are dying, what are some of the risk factors? We'll say things like eclampsia, which is having high blood pressure and then having a seizure, or cardiac disease, like I mentioned before, so cardiomyopathy, like Erica Garner had, some blood clots, right, like Serena Williams had. They're having history of having a hysterectomy while you're pregnant or at childbirth. But some of the social risk factors that we don't ask about, but we know are real, are your housing, your income, food insecurity, access to comprehensive health services. The countries that have better outcomes than we do all these social things, right? Finland, Sweden, they're not looking for a biological basis for why women are dying in childbirth. They actually just care for women genuinely differently. They were created from the beginning with a human rights framework where they believe all people are equal. So therefore they invest in health care for everybody. They invest in free college. They invest in paternity leave. So when we do things like want to model a baby box as if that's going to save babies, when the rest of the things that that country is doing includes free college, we are really just buying things without investing in people. And that narrative is how we keep getting bad outcomes and why we spend a lot more money than everybody else, but have the worst outcomes in this country. So when I was in New Orleans as the clinical director after Hurricane Katrina, I was young. And I was a young person in the room. I get to take notes while all the big fancy people would come. And the World Health Organization came. Everybody was coming. You know, the president was coming. I get to go to these meetings. And they were talking about this new idea back in 2005 of social determinants of health. It was this amazing thought that it wasn't just people's genes that determine their health or their bad choices, right? So they have unhealthy behaviors and psychosocial stress, not because they just decide they want to be obese, but because there's all these other things in their life that happen. They don't have a living wage, right? So you stress eat. Or you can't buy salmon when you don't have salmon money, right? You're going to buy what you can afford, stuff in a can, stuff in a jar, stuff that lasts longer. When you don't have transportation, there's some data in New York around, I keep talking about New York because I spend probably way too much time in New York. There's data around having lack of subway stops in different parts of the city, right? So having all those things, knowing that there's parts of New York City that you can get a subway every few feet, and then the parts that actually have fewer, need more resource, you got to walk miles to get to a subway stop. So those are, that transportation lack of access that keeps people from being able to be healthy. And this caused this disparity in distribution of disease, illness, and well-being. But just to be clear that that top of the slide is still empty for a reason. Because although since 2005 it's been exciting that we've been talking about social determinants, as Richard Hofrichter talks about in his book, above this we have a power and wealth imbalance, right? And so there are things like our labor markets, our housing policy, our tax policies, our education systems, all those things are dictated by power and wealth. And so they cause the social determinants. So people don't decide to live next to each other in black neighborhoods because they just like other black people, right? We have root causes for how that happened. And in the US context, those three root causes are racism, classism, and gender oppression. If we were in a more global context, we might add religious fundamentalism, we might add casteism, you might add tribalism, but until you actually deal with the root causes of why you have social determinants of health, you will always have inequities and disparities in disease, right? Because you're going to have rural classism, right? So you're not going to invest in rural places. You're going to have native people who are dying because we're not invested in native. So all those same things continue to play out. So although we want to work on the full social determinants, whatever your role is, wherever you're working, be sure to understand that the importance of the root causes. So racism is what causes us to be harmed, not race. Race is not genetic, it's not biological. God didn't put us on different continents and say don't mix. And all those are narratives that we've had in this country for a very long time. So racial bias can lead to discrimination, but when you have racial bias plus power, the ability to cause harm, that's when you actually have racism. So you hear a lot of people talk about racism as an emotion. People get very nervous. They feel it's a moral judgment. They don't want to say the word. It makes them nervous. I want you to feel really calm. You shouldn't feel nervous about saying it. It's a historic and a current truth that we have a hierarchy of human value based upon skin color in the globe, around the globe. So the good news, once you accept that as a fact, you can stop doing it. Yes, we can change our belief around that because we know it to be untrue. So racism is a social determinant of health inequities. We add determined equities because people act as if now, when you hear things like your zip code is more important than your DNA code, then we just problematize the people who live in those zip codes without thinking about how they were created and what created these zip codes in the first place. So racism affects your body both directly and indirectly. I do a lot of unconscious bias trainings because that's what people feel comfortable calling them. And then I go in and talk about racism, So they all know it, but this is what we do, right? But so it's important to understand that unconscious bias is real. I don't know if any of you taken unconscious and implicit bias tests online. Anybody taking it? You should take it. Good. I took it. Turns out I'm biased against old white dudes. I know y'all are shocked. You would have never guessed, I know. But it's based upon my experiences. And so all of us have biases based on our experiences, based upon what we've seen, what's happened to us. So what I do is work on my bias. So that means I lean in, not run away. So that means I have to individualize when I meet them. That means I have to stop stereotyping. I don't group them all into one thing. I fly a lot, so I have a lot of miles. I get put in first class. People ask me a lot about politics. I have to not group it all together and not make assumptions and have a normal conversation. It makes me live longer when I can do that. So you too, if you have a bias, you can work on your bias. You will live longer if you can stop stereotyping and move forward. Dr. Kamara Jones, the past president of APHA, has created, or not created, she has the different levels of racism that we now can use inside the public. And I would argue that public health is getting a lot better at talking about this and using this in their teachings and understandings. I think health care has a longer way to go. And so we're really starting to work with providers, clinical providers, nurses, doctors around understanding the impact of racism and how it works inside their institutions. But I think APHA and others have really led the way in this conversation around racism and making it and showing that just like health is not an individual choice, but there's a health system, that racism is not individual choice, it's a system. My favorite book is Ibram Kendi's book, Stamped from the Beginning, The History of Racist Ideas in America. And he has the Anti-Racism Institute at American University here, and I get to do some work with him around maternal mortality. But he talks about, because the question is always, what came first, racism or racist policies, like chicken egg, what happened? And really, he says that people use racist ideas for their own personal to get things for themselves, so for their power. So power imbalances creates these racist policies. So if you are a politician and you know that you can say some racist thing and you'll get more political power, you just use it, so it evolves. So that's why you can go from the idea that black people were inferior so much so that you could own them, to that you could segregate them, so now that you can do things like not give them insurance, right? So like it just evolves, the idea of having that people have different value. So in the past, so we can use political action currently to undo these deliberate political actions. So this is the history of my own field, OBGYN. Dr. Marion Sims, one of the founders of obstetrics and gynecology, went around the country doing surgeries on 3 women who were enslaved without any anesthesia. He created the speculum, so there's some smart folks at MIT who are doing unhack the speculum, right? Because think about what he believed, that the women did not feel pain because they were able to tolerate the surgery. So we still have that belief system inside of our healthcare system today. When they ask residents, they believe that black women don't feel as much pain. So there's something magical about more melanin production that gets to your pain. So I have no idea how that would work, but there is a belief around that. So just know that when you know the history of your own institution, then you have to think about all the ways that plays out and how we treat people, how we care for people. I also attended Tulane. There was a physician at Tulane, Dr. Cartwright, who created a disease called drapetomania. And it was a disease if a slave wanted to escape. It's in textbooks that they would whip them. If they looked a person in the eye, they could cut off a finger. So the treatment was wanting to be free. So of course we have T-shirts that say drapetomaniac, because I'm always trying to be free. So just know this history inside of healthcare is so important. And that you should know the history inside of public health as well, so that you have a real accurate understanding of then how does that play out in the current things that you do and how we don't have as much grassroots organizing. So we really want you to move upstream, away from this idea that what your job is to work on people's individual behaviors and to change them, but really what are those power and wealth imbalances and what is the social structure that we're going to do in order to improve outcomes, and how we need grassroots organizing and grassroots organizations in order to get that done, because they're actually close to the people, right? You're not going to figure that out sitting inside of a mayor's office, or sitting like I was with the World Health Organization. Those people are so far removed from the members that you're talking to who need services, that their ideas will not be something that's replicable a lot of times in communities. So what we've been able to do through our organization is I was able to testify for HR 1318, which the president signed into law that gave about $40 million to actually start trying to count maternal deaths in the U.S. We haven't had an accurate count since 2007. So the numbers that you see, you'll see it say something like 700 to 900. That's a really large range. The reason it's a large range is because we don't count maternal deaths. We work with maternal mortality review committees. We have Black Maternal Health Week coming up, April 11th through the 17th. We're also working with quality collaboratives at the state level and with IHI. They're wanting to build an equity framework. So how can we have grassroots change? Well, first you have to listen. You have to always center the experience of the people who you're working with and use the resources for the greatest impact with them. You have to connect to and build trust with patients and with oppressed populations. The idea that you can sit on high and then create, and they're just going to want to come to you because you're so smart in a fancy academic center or there's not going to happen. So really we have all that history that I talked about from, and I could have gone to more recent history. We talk a lot about Tuskegee and others, but there's a lot of things you could talk about. So you have to build trust. You have to invest in community engagement and participatory policymaking, and that is hard for us to do inside of public health because we haven't done that in a while. But how do we really engage with community members to be a part of the policies that we're making and develop deep relationships? There was an assumption in Baltimore that the patients were going to want to have more policing because there was so much crime. So when we actually did community engagement, the community members wanted more housing. So we will go way left when we don't actually talk to the people we need to work with about what their needs are and what their desires are. Storytelling humanizes issues. We've spent a lot of time trying to get articles in media because when you see the people like Shalon, who had a PhD, who worked at CDC, who still died after having her baby, it humanizes it to not just say, oh, 900 women a year die in childbirth in the United States. So really ensure if you're going to do this work going forward that you have storytelling, that you build a culture of storytelling, that you, when you say data, that you don't think that narrative is not important. It's not just quantitative data. You need actual human stories to go along with the quantitative data. So this is my Flint story. So I might get this wrong. I'm open to correction. So there was a pediatrician in Flint who she saw that her patients were having issues from having lead. So she kept calling the health department saying, hey guys, my patients are having this high lead level. And the health department said, we've tested the water. It's not an issue. It's not an issue. So finally, they got outside consultants to come in, and they tested the water differently because there's two ways to get water back then. I don't still know if this is true. Some of the water comes from the Flint River, and some comes from Detroit. Am I getting this right so far? Yeah, okay, good. And so when you test it and you average it out, it did seem normal. But when you did it based upon where the water was coming from, there was a significant part of the city that had a higher rate. So ignoring the people and not listening to the voice of the community, you're going to keep having your data be incomplete, and you will create poor policy. So every time you think about policy that you're making in public health, if you're not talking to the people, then you are going to cause actual harm. The same thing happened in New York. We were able to come together with the birth justice defenders, and they brought down the Marion Sims statue, right? So there was a statue to the doctor that I was talking about there's another one that we're still working on. There's about 3 of them in the country. But in New York, we were able to sit across from the New York Academy of Medicine. And this is a really big win because we don't want to idolize people who've been harmful to us. We're in a documentary titled Death by Delivery. You can do phone calls, you can do emails. These are all advocacy grassroots tools that we can use in public health. When we are afraid to advocate with the people that we work with, and we are afraid that that's not our job, we are also saying we're not willing to really do the work of public health because that's not what we came from. Advocacy, the fear of not having advocacy makes us bureaucratic and not actually working with the communities. The Black Mamas Matter Alliance I'm on the advisory committee of, and this is at the Mother House. If you ever go to Atlanta, you have to go to the Mother House and take a picture on the steps. That's really where Reproductive Justice was founded. And like I mentioned, we have Black Maternal Health Week coming up. If you go on the Black Mamas Matter Alliance website, you can see the different ways you can engage. There's going to be activity. Last year was our inaugural one, and we had a lot of events. And so really just heightening this idea and making sure that we center the needs of women of color. We created a black paper, not a white paper. And so it's called Setting the Standard for Holistic Care of and for Black Women. And it really talks about all the things you need, like access to doula services, a more robust midwifery community, how OBGYNs can be part of a system. The countries that have better outcomes than we do have a much more robust system of midwifery care. And we really need to think about why we don't have that and what happened to granny midwifery in this country, the beginning of midwifery. We are my organization, the National Birth Equity Collaborative, is the primary investigator for a Robert Wood Johnson grant, and our subcontractors are Stanford, CMQCC, and the ACOG, Alliance for Maternal Health. So that's decolonizing research right there. For our Robert Wood Johnson to choose the small nonprofit to be the PI, and our subcontractors to be the big academic institution, and American College of OBGYN is a whole power shift dynamic that we have to work through every time we talk. But it's an important move, and our job, though, is to really listen to and create a patient-reported experience metric for disrespectful care. So across the globe, there's a standard for respectful care. For maternity care, we do not have one in the United States. So what would it look like for us to have a respectful care standard? Because we realize that the women are dying, white or black, everybody, because they're not being listened to, they're not being heard. They say things about their hemorrhage, they say things about their pain, and no one's following up on it. So really, what would respectful care look like? So we're hoping that once we build up with these larger institutions, that it will become institutionalized, and they will start using it to hold themselves accountable. And so then just some grassroots examples. We've having transportation, making sure that you work on your uninsured rates. These are things you could do inside of public health. We work with the New Orleans Health Department around we have a lot of people in New Orleans who work in hotels, and they don't have access to paid leave. What does it look like to have the Tourism Bureau working on paid leave, at least for moms, right? It's a small ask. You've probably seen food pantries, and these are normal the things that you should be doing inside of grassroots that are also should be inside of public health as one opportunity. And just the reason that we need these strategic partnerships, like universities and academic institutions, local and state advocacy organizations, local media outlets, racial and social justice organizations, because when you have this collaboration, you can get greater funding, increase your opportunities for impact, have data intel, and develop trusting relationships. And you should think about stepping back as a large organization and allowing the smaller organization to lead, and you actually learn from them. So this is my favorite slide, my last slide, and it's really comes from Ibram's book. He tells a story around Abraham Lincoln, who we all love, right? Free the slaves. I'm happy he came. I'm happy he was the president. And so I have built up in my mind a narrative about who he was as a human being, right? I think he must have been really moral and just and good, right? Can we agree we think that? So he was near the end of the war, and he brought the top 5 black folks into the White House. So you can picture it, like the top 5 black people coming in, and he sat them down. He said, look, guys, I have like $3 million. Liberia says you can come. Why don't you take your people and go? And so the black folks were like, no, we've been here. We built this country for free. We're staying, turns out. And he said, but you're being so selfish. If you would just leave, the war would end. So at the core, although he was a good and moral person, he still was a segregationist because he still believed that black people were broken and needed to go back to Africa. We had served our purpose, we had built this country, and there was something innately different about us. We were something that could not be fixed. So if you are doing this work with us, if you're really doing public health and you want to do grassroots work, you have to believe that we're all equal. That makes you actively anti-racist. Once you start with the premise that no, we're not broken, that you don't need to fix us, but there are systems and structures that are harmful to us, then you can then be a part of the movement for anti-racism to end disparities in public health. So that's it. Did I take too much time? Okay.
Thank you very much. That was a wonderful way to start the afternoon. I realized when you mentioned Dr. Kamara Jones that I didn't introduce myself at the beginning of this whole thing. So who is this old white woman standing up here talking with you? I'm Pam Altonen, current president of APHA. It's my pleasure now to introduce our moderator for the panel, Steve Sternberg, who is the Assistant Managing Editor of Health Initiatives, U.S. News and World Report. Steve is, let's see, maybe I need to advance the slide. Is that better? Yep. Steve is a veteran award-winning journalist. He has reported on most, if not all, of the major public health stories that have emerged over the past 20 years, including HIV/AIDS, human genome, Hurricane Katrina, hantavirus, the anthrax attacks, and the Haiti earthquake. He was the architect for the health ratings developed to identify best hospitals and best children's hospitals for USA Today. His role at U.S. News includes being a liaison with others on assessment parameters for the healthiest communities. Having served as a youth coach for both baseball and hockey, tells me that Steve believes in the importance of physical activity. He received his baccalaureate degree in English literature from Ithaca College and completed graduate work at Stanford University and Johns Hopkins University. If you had an opportunity to read his May 2nd, 2018 U.S. News and World Report article, A Healthy Return, Advocates Investing in Troubled Communities Hope to Bring Together More Than Just Surface-Level Change, you will know why he's an excellent choice to moderate this panel. Steve.
Wow. Well, thank you, Pam. You've telescoped about 30 years of history into about 5 minutes. So a couple of things. Just, I was an architect of Healthiest Communities, which is a U.S. News and World Report project that evaluates a whole bunch of social determinants for 3,000 counties around the United States. We looked at 81 indicators, and I'm not going to talk about that in depth here because I think we're all here to hear the panelists. But, I want to thank the the folks at the Aetna Foundation who are our collaborators and sponsors on that project. And I want to thank the Public Health Association for inviting me to speak here today. Having covered all of those issues, I have to say that I've had a lot of contact with the kinds of issues that Joya mentioned in her talk. But I'm, I've always viewed reporting on public health as kind of a ticket into other kinds of worlds and other kinds of communities. You cannot write about public health without visiting barrios and Native American reservations and black communities. But I want to make it very clear that I understand this, that I'm just a voyager in those worlds. I don't live in those communities. I haven't had those experiences. And to the extent that I can, what I'm trying to do is bring to the fore the voices of people who have had those experiences and who can tell authentic stories. And that's really why we're here today. One of the other things I've learned in that journey is that there are heroes in the streets. People ask you questions. How can you go to these communities in Africa that have been so hard hit by a host of public health problems, and maintain your optimism and maintain your good spirits and come away thinking that we have a future on this planet? And the reason you can do that is because you're surrounded by heroes. There are heroes everywhere you turn. People may not know who they are, but they're there, and actually they're right here. So it's my privilege to introduce four such folks who are working, fighting with some very intractable issues in their own communities, and it's really a privilege to be able to introduce them. So on my far right, I'm going to have to juggle some papers here because they're a little out of order, but we have Pastor Jordan Boyd, who was born in Memphis. He's a graduate of Fraser High School. He's the pastor at Rockwell AME Church in Mecklenburg, North Carolina. He works endlessly, and I'm gonna abbreviate these things because we're going to hear a lot more from these folks, and they can tell you more about their backgrounds. But suffice it to say, he works endlessly for the underserved. He's led the church in receiving the Baum and Gilead Healthy Churches Award for 2019 for the promotion of behavior changes toward healthy living. He serves as an ambassador for the Village Heartbeat Program, which is a 2019 recipient of the Healthy Cities and Challenges Award. And to his left, we have Karma Lewis. She is a neighborhood activist, and from what I gather, Flint's most precious natural resource other than water. She works with Flint Neighborhoods United, a collection of neighborhood associations, block clubs, and crime watches. She's done this for a number of years. She was hired simply to work at a water crisis station on Flint's east side, a position funded through the state of Michigan with federal dollars. They found that they couldn't do without her. So she is now involved in almost every health promotion activity, right, that Flint has going on. So it's a privilege to have her on the panel. Sitting next to Karma is Javier Lopez. And he and I had a really great conversation about all of the stuff he's gotten up to. I mean, he was an assistant commissioner in the New York City Department of Health and Mental Hygiene, and focused on on health equity, and discovered, as Joya said, there's only so much you can do from the top. So he is now working with the Red Hook Initiative in Red Hook, Brooklyn, and we have a lot to talk about when it comes to Red Hook. And on my immediate right, I have Deb Thomas Sims. She's with the East End Neighborhood Revitalization Zone project in Bridgeport, Connecticut. And folks in Bridgeport, and especially in the East End, are dealing with some serious challenges. Her project was another recipient, the 2019 recipient of the Healthiest Cities Challenge Award. They're being recognized for their pop-up market and cafe, which is in the works. It should open its doors very soon. that wouldn't be such a big story anywhere else, but in the East End of Bridgeport, Connecticut, if you want to go to a grocery store, you have to travel, 20 minutes by car, and about 45 minutes by public transportation, and you have to carry all those groceries home. So this is a big deal for folks in Bridgeport. And I want to just stop there, and I want to begin the conversation with everybody here. And maybe the way to go, at least in my view, since we are Voyagers, I'd like to start with Pastor Boyd and just ask him, can you talk a little bit about Mecklenburg County, about Charlotte, North Carolina, and what your community is like, sir?
Good afternoon. Thank you again for the opportunity to come and share with you here today. Mecklenburg, North Carolina is a great city. It's a great place to live. Its size is disproportionate for a city its size to have two major sports teams, the Hornets and the Panthers. That's in part because I think now we're the second largest financing city in the country, with Bank of America and Wells Fargo. But underneath the veneer of the success and sports and the massive gentrification that's taking place, there is a very dark side that exists that began to become revealed through the Harvard study that listed Mecklenburg County as 50 out of 50 major cities for which someone born into poverty 30 years later would still be in poverty because of their inability to upwardly move throughout the traverse of success and the inability to access through social capital and other means opportunities that would allow them to lift themselves from that state, as well as a large pocket and population of increased AIDS and HIV cases in Mecklenburg County, and a disproportionate, as it's known in public health speak in Mecklenburg County, the crescent zip codes that have highlighted areas of persons with high chronic disease markers. I'm happy to be a part of an initiative that began with a dreamer by the name of Cheryl Emanuel, who is a public health director who has spent the last 30 years working in Mecklenburg County and has realized, unlike many, that if you want to reach the African American community, the way to do that is still the gateway through the church. The African American church is still the one institution that, while communities change, the churches find a way to stay a part of the community and becomes an avenue by which community organizations and organizers are able to tap into a community otherwise unreached. And so I'm happy to be here today to be a part of this discussion.
Thank you, Pastor Boyd, and I'd like to just give a shout out to Cheryl, who's here with us today, and hopefully she'll be able to join us in the discussion. Karma, a couple of quick minutes. Can you introduce yourself and Flint, your community?
My name is Karma Lewis. Maybe I just need to speak up. Okay, my name is Karma Lewis, and I was born and raised in Flint. I moved away after college and ended up returning. And upon my return is when I actually noticed a difference. Even though I was back and forth visiting family, because my mom's still there, I really didn't know what was going on until I moved back. And I noticed when I look out my window, things were different. There was a lot of abandoned homes falling apart. And even though I saw this, I still loved my hometown. I have lots of ties. And then the people that were there were still the same nice people that were always willing to help. Fast forward to the water crisis, and it was amplified where people, residents, were so much more willing to help one another. And I have found that people that come to Flint from elsewhere for the first time, they realize that this is not what I thought. Flint is not what I thought. I thought it was a crime-ridden place. But in reality, they come, they meet good people that's willing to show them around and allow them to experience the reality of Flint. And for those of you that have never been there, you have to come and check it out. I love my hometown.
Thank you, Karma. Javier.
So good afternoon, everybody. Just want to co-sign that Stamped from the Beginning should be a reading for all individuals who are in justice work or in any type of field. What it really gave to me as a reflection was how assimilationist principles and neoliberal policies have converged in this country in a way that has really eradicated any pipeline to liberation for people of color. I'm usually an optimist, but my pessimism reigns supreme when you start understanding the history and how movements have been stymied by policies. And that book just really gives a perspective that I feel everybody in this room should check out and read if you haven't. So I'm Javier. I'm born and raised in New York City. I've had the privilege and the honor to serve many neighborhoods and communities throughout New York City over the last 12 to 15 years. I'm presently working out of the borough of Brooklyn in the Red Hook community of Brooklyn. For those of you who have ever traveled to Brooklyn or ever been to Brooklyn, Red Hook is a neighborhood that has really been a part of the New York City fabric for many, many years, but has gone through various descriptions in those years. And I think when you think about Stamped from the Beginning and many books that talk about how people of color come to certain neighborhoods, it kind of plays out in neighborhoods in New York City that have very much been segregated for a number of years. But in Red Hook, I'm privileged to support a community that really has been separated by a lot of different things. It was separated by Robert Moses, an urban planner and someone who really eradicated and destroyed people of color communities in New York City by highways. So the highway that really has segregated Red Hook, Brooklyn was established to really, create better pipelines and pathways for industry, but in many ways it created a neighborhood that was forgotten about. It went from a longshore fisherman community to a community that then became part of establishing the largest housing development across the country under the Roosevelt administration. It's one of the oldest holdings of public health developments across the country. And as a result of that, they've fallen on hard times as a neighborhood. When Hurricane Sandy hit in 2012, the organization that I work for, the Red Hook Initiative, who had previously done work on maternal health related areas and women's health related areas, because it came out of a hospital grant. In many ways, that was the origin of the organization I work for. They were there in the front lines supporting the public housing projects and the New York City public housing residents and getting access to food, water, to communication mechanisms, to really get connected to the wider New York City, but in the country, because in Red Hook, it was like I described, it was separated by a highway. In so many ways, that community was forgotten about by many others. And what I see in Red Hook on a daily basis, it's the reason I left the health department, is it's a neighborhood that creates a level of responsibility for action. You can't be walking around serving the folks that make up 70% of that neighborhood, which are predominantly people of color, public housing residents, and not have a response to the issues that they have. We serve the youth predominantly at an organization, but we work with the families. We celebrate every young person that leaves to go to college, but we think about what type of environment that person's going to come back to. Do we want to create this pipeline where people have to leave and never come back? The sister just said here to my right that she came back to Flint, Michigan. I want all the young people that go through the Red Hook Initiative, that go to college, to come back to the neighborhood and be a part of the liberation movement so they can own the land that is being taken away from them, so they can own the apartments that are going to be privatized if we don't get our acts together to figure out how we can fix the public housing community. These are all areas that I'm interested in working on with a public health framework. I left the public health department several months ago because I became disillusioned that government really cared about people. I don't think government cares about people. I think grassroots organizations and organizers care more about people than government ever will. I think government, though, if pushed, and if the voices of the many can come together, can work towards a systemic change that will take a couple of generations to be felt, but we have to work in that direction. So I'm honored to join my panelists today, and I'm also honored to be a part of a discussion that lifts up the organizing community, which in many ways are being taken advantage of by high academic government institutions and petri dish operations as opposed to problem-solving operations.
Good afternoon, everybody. My name is Debbie Sims, and I'm from the East End NRZ Pop-Up Market and Cafe. And I'm also going to introduce two of my partners who are here with me today. It's Deborah Cavanis, and she is the president and CEO of the Greater Bridgeport OIC, who are our job training partners. And, I don't know, Detective Harold Dembo, who's a retired detective who now works for the FBI, who works with us on the violence prevention side, dealing with our youth who are at risk out there in the street. So the East End pop-up market, let me talk about Bridgeport a little bit. So I love Bridgeport. I'm a 30-year resident of our neighborhood, probably 40 years, but I like to say 30. But and I'm going to start by saying I had this discussion with a group of our NRZ members. So this is the way they describe our neighborhood, and we're going to change the narrative. So East End, prior to us opening a pop-up, was a 30-year, the longest standing food desert in the state of Connecticut. We have the highest rates of obesity. We have the highest rates of asthma. We have the highest rates of hypertension. As of last week, our gun violence is out of control. You name it, we have it. I said, when we write grants, that's how we have to describe our neighborhood. We have to change that narrative, and that's what we're going to do through our work that we're going to do out of this market. So when we came up with the concept for the market, one, it was really to look at addressing the issues, providing fresh fruits and vegetables to our neighbors. So I live there. Everybody in the world has come to our neighborhood with all these flashy ideas, trying to open a store in our neighborhood, but no one was able to get it done. So the group of us, I call us a trio. There's one, well, it's more than one, but there's two Debs and another person, so that we were sick and tired of being sick and tired, and then we figured out a way to get it done. Dembo, who's on our I call our second part of our team, addresses the violence component, because we realize that we have to have a neighborhood that's safe for people to come to. So we all got together and surveyed about 500 people in our neighborhood, and looked at what we needed to get done in order to address the issues that were there. So we needed food, we needed jobs, and we needed to address the issues of violence in the neighborhood. Collectively, we all had a part of that and took a part of that and made that a reality for us.
Thank you all so much. So just thinking about the themes that emerged in that discussion, we all heard very people from very different kind of places with very similar themes, and interestingly enough, some very maybe unexpected ways of dealing with them. So we have, and I know this from speaking with Pastor Boyd just before the discussion. They're dealing with a lot of gun violence in Mecklenburg as well, and yet we're here to talk about behavior change, healthy behaviors, trying to improve health outcomes, and we're trying to use that as kind of a vehicle for transforming communities away from violence toward healthy behaviors, toward access to health care and food, and so I wonder if I could just challenge the panelists, maybe starting with Deborah and Javier, to talk a little bit about some of these population health approaches to youth violence. And one of the things that emerged in our discussions that I'd like to ask specifically about is that Javier was telling me that in Red Hook, the youth are concerned that the police presence actually begets violence, and Deborah was telling me that they've had so many shootings in the East End that they need to get police in there now to stop the violence. We're privileged to have the detective here, I think probably can help inform this discussion, and I would also welcome Pastor Boyd's input on this too. But Deborah, maybe you could start us off.
So in our community, we privileged to work with the police. I mean, it's not easy at all times. We're grateful for Detective Dimbo, but we have a great working relationship with him because we have to respect the law. There is no way around it. And what we're faced with now, the last couple weeks, it's been very difficult, but they have access to information and they have protocols and procedures that we do not. And what we try to do is we work with parents and we work with siblings and we try to intervene on their behalf. And when we can't work with them, then we have to turn them over to a Detective Dimbo. And then if he cannot work with them, then he will turn them over to the law. So as mothers, we work with mother groups. We bring them in. We have conversations. We say, we know your son. We know your daughter is out there on the street. What can we do to help bring this kid in? What can we help him? We know he has a gun. We know he did this. We're here to help you. What can we help? And if he can't, then we need to do something differently.
And let me ask you just what role the market plays in this.
So the market has become, I love the market. So if you haven't seen our video, you got to look at it. The market has become the gathering spot. It's the safe spot. It is the spot where I knew it was going to change lives, but I didn't realize the impact that the market was going to have. Can I share a story?
By all means.
Okay, I'm going to share this story. So when we're not open up because we're still waiting on a door, but a mother's group meets here, and it's called Yana. You Are Not Alone, and there are moms who lost their children to violence. So they were having their meeting there, and a mother showed up at one of the meetings. So she came there because she heard this group of mothers was meeting there. But she was a mother who lost her son to suicide. And she walked in, she goes, I know this is not the right meeting, but I didn't know where else to go. So I'm sitting there listening, and I was like, wow, so we have a mother, she comes to this meeting, but we open the door for Black women to begin a discussion to talk about suicide. So for me, that was huge because we don't have those conversations in our community. So I'm like, this market, is going to change more lives than we ever realize it's going to do. So everybody knows now if you have a problem, If there's something going on, then go to the market because they're going to help you figure it out. So I got to thank Aetna for that because they saw a vision in community that, a lot of people just don't get. They got it. I don't know who foresaw that, but they got it.
I'm hearing some similarities with Red Hook Brooklyn.
Well, there are some similarities, but there's some differences for sure. I just want to note that I'm an abolitionist. I don't believe in the prison industrial complex that's been erected in this country and how it's played out in neighborhoods of color. So I just want to frame my thoughts around that. And to be honest, the work of Red Hook Initiative around violence, anti-violence work, was led through a participatory action research process that had young adults from the neighborhood leading the research. It was dedicated to a member of the neighborhood who was killed, and a family member stepped in, and family and friends came together and led this research project. You should look; it's located on the website, the Red Hook Initiative. Look it up. It's an anti-violence work, and what it calls out is it explicitly says that an investment to get around the disinvestment in the neighborhood is necessary. So the investment in public spaces, the investment in all the going against all the risk and protective factors, or going for the protective factors, need to be looked at. So those of you who are in public health research, you know about the protective factors. Well, this research calls it out and says you need to invest in the public spaces, you need to invest in more programming, you need to invest in basically a humane way of how a neighborhood should look. And what's interesting about this is that, of course, the public safety and policing community looks at it as a slap in the face. He's saying, don't invest in cops. And the young people are saying, no, we don't need to invest in cops. You know what the budget is for Red Hook? It's $49 million budget, for public safety and policing, compared to budget allocations as it relates to youth development and as it relates to public spaces. All the public spaces are going to be gentrified. So the youth see it. They're not blind to it. What ends up happening, though, is that the research that we have now needs a next step, and we're working on a campaign that puts that research and puts it into action and puts it into the policymakers' hands. It really turns it into systems change in policymaking. We also have, as an organization, some farms that are in the neighborhood. So we have 2 farms. One is a farm located in Red Hook on Columbia Street. If you ever go there, it's a huge acreage. It's like 2.75 acres of a former concrete cement baseball field that was converted into a neighborhood farm. And we also have a farm in the New York City housing development in Red Hook. Our goal, which also speaks to the anti-violence work, is that these public spaces are utilized for the New York City housing residents, but also that every produce item that comes out of these farms get to the housing residents first, the public housing residents first. This is not a glamour and glitz project where the white gentrifiers can come in and feel good about themselves, which usually happens at a lot of these community farms. This is actually a project that is dedicated towards ensuring that those who do not have access to produce, those who have never seen a supermarket come back after Hurricane Sandy, are able to go on a weekly basis and pick up fresh produce for the public housing residents free on the grounds. And then for those who have, EBT access and everything else, we want to make sure that they have access at the larger farm. So if you see the connection, the report calls out for the activation of spaces, the organization. We have responded by making sure our farm work speaks to that, but also at the same time, we're not losing sight of the fact that there are other public spaces and other disinvestments that have to be looked at in order to rectify premature mortality, which is something that is a big deal in the neighborhood of Red Hook, especially for African American men 14 to 22 years old.
So living in these neighborhoods under these kinds of pressures, generates something that's commonly discussed now in the social determinant realm, which is toxic stress. It's something that Joy mentioned. Yeah, sure.
Make one more comment too.
Sure.
So we worked with our state and local representatives to change the laws with our youth, because there was a time when they were arresting all of our kids. And Now they can't do that. So, oh, louder. I'm sorry. I said we work with our state and local representatives to change the law for our teenagers because there was a time when they were arresting all of our youth. So the law was changed a couple years ago, and now they can't do that. And I'm going to tell you, as a result of that, it has been quite challenging as to what we do with that. So me and a bunch of us, we were like, oh, every time we turn around, our kids are getting arrested and they're going to have records and, it's out of control. And now we're back at the table again because no, we don't want our kids to have records and we don't want them arrested. And now I want you to talk about it a little bit. We have these same 15 and 16-year-olds who are now caught with these guns and they pick them up. They can't do anything with them. So now they are wreaking havoc in our neighborhoods. So we go back to the table again with the chief, with our state rep, with our senators, and they're looking at us like, well, you asked us to change the laws. What do you want us to do? So now we're back at the table, trying to figure out, what do we do with these kids all over again? Because yes, there was a time when every time we turned around, our kids are the ones who were getting all the records.
Like Red Hook, which was cut off, as Avi said, by the BQE. East End was cut off by I-95. So it's a neighborhood that was access. You could access downtown Bridgeport from East End, and you really can't anymore without going around and about. And so you have these cauldrons of these kinds of frustrations, and I saw Carmen pick up her mic. I know Reverend Boyd probably would like to weigh in on this too, because I know in Charlotte they're dealing with similar kinds of issues.
So for me, I think it's important and I know the panelists will probably agree, is that in many of our neighborhoods, the challenge of affordable housing has driven the level of trauma and stress that people are experiencing personally and collectively, especially children, and their behaviors and acting out in schools and in communities to a different kind of a level. And we are, I think, in many ways misdiagnosing it as them being just juvenile miscontents. But when you move 10 times in 18 months, when you live in a car, when the focus is to get the $63.25 for the next day's stay in an extended stay motel, you feel the stress of your parents. So I'm happy to be part of a coalition of partners that I think is the beginning of something that can have a larger impact beyond chronic disease. As I was sitting here listening, I'm thinking I grew up in a neighborhood. My home was Memphis, Tennessee, in a section called North Memphis. And across from my elementary school was, a landfill. I never heard of the word social determinants to health back then. I just thought it was okay as a kid growing up from 1st to 6th grade to play on the landfill. Many of the kids that I went to school with got their clothes and bikes from what we call the dump, but today it's called the landfill. I didn't know it was toxins coming from the landfill. It's now the Department of Transportation bus facility. But I realized that when my father came from the war in World War II and couldn't get a job and went to work at a major employer who was making, and the African Americans were making 3 times less than their white counterparts who had been there longer. That created a stress for him that he brought back to his family, that impacted all of us and forced him into, he was a brilliant guy, brilliant man, loving father, but he was stressed all the time. I always wondered why he was so stressed. I didn't know that when the wrecker came to pick up his truck that it was because he didn't make the payment. And I didn't know why he was protesting in front of the bank, that it was because the bank didn't want to give him a loan even though he had assets. And our house, although it wasn't worth much, was paid for. He had capital, he had equity. And so as part of a coalition of pastors, multi-denominational pastors, a coalition with the hospital, American Heart Association, Public Health, the YMCA, we've been able to move the needle on chronic disease. I think the next area we must look at is trauma. That trauma is underneath. There's a family we supported of a mother who had just been released from the hospital. 2 young kids joined our church. We sponsored her, got her job. Okay, this is the last time. Thank you. Got her a job, clothes for her, her family, sponsored her for 5 months, found her a place to live, created job training. She is not mentally able to care for herself or her children. She lives on the street. She uses her children as part of the panhandling that takes place. That's trauma. She has other homeless women like her with children now that she has moved in with her. Every day is just to get the $63.25 to stay the next day in the extended stay motels. Many of our people, when I say our people, people of color, I've experienced a kind of trauma that Dr. Perry talked about that is not measured or talked about even in them seeing their physicians, nor is it experienced as I have in my losing my physician of the last 20 years who took great care of me because I inherited from my father high blood pressure. And to no fault of her own, the hospital brought in a young Caucasian doctor. And I said to her, I'm taking a new medication that was given to me by the pharmacist. Will it have any kind of different effect for me as an African-American male? And her response to me was, why are you asking me that? I'm not here for you to test me. This was last month. This wasn't 1960. This was last month. And so I realize even today that there is a huge chasm that exists in the cultural relevancy that exists in policy and systems and changes. And I know we talk about governments, but governments are not abstract entities. They are made up of people who are elected and appointed to serve the people that they were elected and appointed to serve. And so without the community and the community's pressure and holding them accountable, and you say, well, I don't have time to do that. I don't even have time to go and check my kids. Well, this is where I come in. This is where pastors and community activists and people who dedicate their lives to helping hold community appointed and elected officials accountable. And it has not been easy, even with Cheryl, in her vision to say, hey, listen, we can move the needle on this in partnering with faith-based and other organizations coming to the table. And that was a great resistance This is the culmination of a 10-year-long initiative that was just 3 years ago decided to be piloted by the county to say, okay, well, you guys just go away. Take this and go. It's not going to work. And all of a sudden, Aetna comes along and stamps the work, and it blows up, and now they want to trademark it. No, literally. Trademark it. And I think the word I heard earlier was colonization. I wrote that down. Yeah. But you can't colonize what you don't understand. And so it's more than just a model drawn out on paper. Without an understanding of the dynamics of relationships, of how people are connected and what connects people and how you relate to people, it won't work. Without understanding the value of transparency, without understanding the irretractable value of trust and being truthful and honest and open, it's not going to work. Because we're accustomed to governments lying. Or let me say, misrepresenting the truth. But believe it or not, we can actually work together because, as it was said, and I have to applaud our new health director, Gibby Harris, who has come in and really tried to help Cheryl move this forward. I think caught in betwixt and between, we all need a win. We all want to win. We want to help make the community better. And we want you to do all that you can. You have access to things, resources that we do not, and we have access that you do not. And you're just showing up doesn't mean we're going to roll out the red carpet. Because historically, your coming has not been genuine and authentic. And so you must come with that understanding. And when that takes place, an open conversation can happen, and we begin to realize our unconscious biases. Not that we don't have them, but we don't acknowledge them and don't see them. But when we acknowledge and see them, then we can work through them individually as individuals who have a shared interest. I believe I must remain optimistic. I default to the faith factor, that our faith is greater than any kind of obstacle that we face, and that we can solve all problems when we come together. And that sometimes it has to get really, really bad for us to come together, unfortunately.
Let's.
Can I jump in here for a
I
second?
was hoping you would.
Okay.
Yeah, thank you.
Guess it's on. My issue actually in Flint was the lack of police. Now, I'm pretty sure everyone in here knows that when GM left Flint, Flint was left broke. We could not afford the police that we had. So they were let go. Most of them were just gone. And we were left basically to defend ourselves. And we had to deal with reality. Police do not prevent crime. They're the one that comes in after something has already happened. So in order to prevent crime, we as residents in our neighborhoods had to step up and do something about it. Now, Flint Neighborhood United started because of that. And what we did was we started to share what was going on around us. And some of the neighbors in Flint had already solved those issues. So they would share with other residents this is what we did in order to combat that particular type of crime. Now, there is this program that I'm not even sure where it came from, but it was called CEPTED, Crime Prevention Through Environmental Design. And so a lot of residents started to take this workshop. And one of our funders, Ruth Ma Foundation, they're the ones that actually brought the people in, the organization in order to teach residents. And so residents started to use this particular type of program on their own properties. It is basically where to put lighting around your homes, or how to trim hedges so that people can't hide behind them so we can see what's going on. And a lot of people kind of expanded that because there's a lot of vacant land and vacant properties and abandoned houses. There's some people who started putting these solar LED lights, I'm not sure if I'm saying that right, on these vacant homes, because when the sun goes down, it's dark. And even though there may be street lights that all work on this block, because of the abandoned properties, it's more dark. And so that's one of the methods that people use in order to make their environment safer. And then there's also, we have a community tool shed. And when I tell people about the community tool shed, it's a place that you have to actually go and see. But they have zero-turn mowers for residents to use because of all of this vacant land. And the city does not have any money, again, in order to cut grass. Grass at these vacant properties are cut twice a year. Twice a year. Not good enough. Because people that were breaking into houses was taking those things that they stole and putting it into tall grass to come back and get later. So residents are able to go to the community tool shed, learn how to use a zero-turn mower. The community tool shed has a truck and a trailer that will deliver it to you. I, myself, every other Friday, cut 8 lots. I don't do my own because my stepfather's kind of picky. But it helps. It helps to be able to enjoy what you see from outside your window when you look out your window. And our community land bank, Genesee County Land Bank, actually received hardest hit funds several years in a row in order to demolish a lot of these properties. We have some neighborhoods that complain about that because they're historic. I live in a historic neighborhood that was kind of the opposite. We wanted to see those buildings gone because we knew that our population, the housing stock, was based on 200,000 people. We now have less than 100,000. We did not see Flint coming back like that anytime soon. So a lot of those properties were demolished. We're happy about that. And then the remaining properties that's still there, there's some resident groups that have started to purchase those properties and put them back into commission. We have, they call them returning citizens, people that are coming back from prisons. They are learning how to put those houses back together. So they're getting a trade. They're learning how to do these things that we need. We need these houses put back. And then they are able to actually purchase those houses for their families. So all of this is just a step in that right direction for crime prevention. Because we love our police. We love them dearly. We need them. But they need us too. This is basically teamwork. And we have a lot of residents that's so desperate for a better quality of life that they're willing to work together.
I don't know how to follow this. I'm kind of speechless. These stories, I guess one thing I can say just, from the perspective of a journalist, we spend so much time writing about problems that are out there. And one of the things that we're trying to focus on more, and we're doing this at U.S. News, and there are other news organizations around the world that are focusing on this as well, but it's this notion of solutions journalism, that there are people out there who are trying to fix things, and they're incredible stories. I mean, the stories we're hearing today. And these stories need to be told. They need to be heard. People need to, to factor them into their notions about what's happening in these communities that are, off the grid for most policymakers. Places like Red Hook and East End and I'm sure corners of Charlotte, where people don't go. They're not seen. They're just off the grid. And stories like these can put them back on the grid. One other thing that I just wanted to bring up, because I was so struck by it. I mean, I'm learning a lot of history here today and in previous weeks and learning in previous years, really, learning about the causes of these problems that we're discussing. And redlining is a term that's on everybody's tongue. It's still with us. And so when I started seeing stories in newspapers, I brought one from the Post here, about ad practices that have been adopted by the social media giants that HUD is now reviewing because they play a role in housing discrimination. That redlining, at one point was sort of a banking issue. The banks responded to some degree with the Fairness in Lending Act. The Federal Reserve banks are very much involved in investment and fairness in lending practices. And what do we, and we get a news story like this one published on March 28th. The Department of Housing and Urban Development, so we're now, back in talking about housing, alerted Twitter and Google last year that it's scrutinizing their practices for possible housing discrimination, a sign that more technology companies could be ensnared in a government probe of their lucrative demographic ad targeting tools. And there were, I think Facebook was also kind of ensnared in this as well. So it's just a sign that this is not, disappearing in the mists of history. So let me, yeah, absolutely. And I was going to say, if you would like to just lead the audience discussion,
Okay,
that would
be great. This has been so amazing. Y'all are all so awesome. I have to say, I love doing these talks because I also learn stuff. So I'm going to start stealing a lot of y'all's language. So if you hear it again, I try to quote you. I try to say, I got this from Javier, but sometimes just know it's in my spirit to say if I don't say it. So I just want to reflect a little bit on what I heard and how it ties to the earlier things that I said. And then honestly, this article that you just brought up is really a great segue. Because if you think about Ibram's book and you think about how racist ideas just move, they don't go away. We have not dealt with racism. And so the new way, and so somebody said to me that we were calling housing discrimination. So they would call this soft discrimination, they would say, right? So, but I would imagine that when we went from slavery to Jim Crow, that was soft discrimination, right? It's still discrimination. None of us want to go back to Jim Crow, okay? All right, so the new evolution of redlining, right? The ability for federal policy to create neighborhoods based upon race and disinvest in communities of color for decades. That was not just banks that just decided to do it. It was federal government plan, just like Tuskegee experiment was the federal government that did that. These are not just things that happened haphazardly. And they were doing it because they wanted to prove that black men were more impacted by, their brains were impacted by syphilis and white men's hearts were, because they were still trying to prove a biological difference of race. Okay, so that is why I probably spend most of my talks trying to unpack for you that belief, because we're not gonna get anywhere until you stop doing that, until we stop doing that, because we come up with solutions based upon believing that people of color are broken. So the liberatory idea that we can do today is close your eyes and imagine that if when this country was founded, we didn't believe that the only people who had value were land owning, because it's some white men who are really getting jacked up from racism, some land owning white men. Okay, imagine that wasn't who we only valued, that we didn't make every policy, every decision for land owning white men. How liberatory. So even the difference between how we view policing, they had 3 different conversations about policing. all of them are embedded in this idea of we haven't come up with what would we have created, what would we have done. So I think they all have value, but we need to start sitting and thinking with ourselves, what would we really do as a country if we valued every ethnicity, if we valued every religion, if we valued women, what would we build? So that is my reflection. Now we are going to open up to the audience for questions. And I don't know how we did the web questions as well. Yes. So they have mics in the middle. Come to the mic. I know y'all are not quiet. Y'all seem really cool. There's always somebody who starts. No one person is starting. No. We have a web question to do while we're doing. What about Twitter? I know Twitter's been popping. Social media is popping. I won't make my mommy or my godchild get up. Yes.
Your webcam, the live stream, that please send your questions and we'll get them up to the panelists. There are two. The first one is for you, Doctor. And it's a clinical question. And are there forms of medicinal birth control that do not work as effectively with obese women?
So the truth is, even when the pill, the standard birth control pill, the more you weigh, the less effective it is. And so we're supposed to counsel patients over a certain way. And I don't want to misspeak because it depends on the pill that you are on, that you're supposed to know that you probably might need a backup method. So the ones that are working without, think of it as the pill has to go through your entire body versus if you have something that's inserted inside of you like an IUD or you have your tubes tied, those things are less impacted by your weight. So we had to decrease in the beginning when the birth control pill was created. It had a lot of estrogen in it, and so people were having strokes and having different things happen to them. So we decreased the amount of estrogen so that people can live and not have the effects from so much estrogen, but that also is then balanced out by now your body has to metabolize it. So the more that you weigh, the less effective it's going to be. And how birth control works is you don't have an egg come out of your ovary. I'm trying to use really lay words because I realize I sometimes use doctory words and it doesn't work out very well. So your ovaries have eggs and the pill makes them the egg doesn't come out each month. And so if we're trying to control for that cycle, that requires adjusting for weight. I hope that answered the question.
Thank you. And then there's a question for the entire panel, and that is, how can non-traditional students connect to public health entities if they don't have the experience, but they want to engage in the work that you're doing at the community level?
In Flint, we have AmeriCorps workers, and they are saturated throughout our community. So all they would have to do is get with a particular organization that they're interested in volunteering for, because AmeriCorps workers are basically volunteers. They do receive a stipend, but it's not quite minimum wage. So if they're interested, that's the route to take in Flint.
Since it's a question that really is germane to every neighborhood across the United States, I would just say, you can go to any not-for-profit, social service, faith-based organization, you can volunteer. Like, it's not that hard. I think a lot of students are thinking they have to be found now. We're busy, so come check us. Come out, go to your neighborhood, understand the areas. If you're an epidemiologist, a surveillance person by training, you can look at the data, and then you can find an organization that's trying to address that data in that neighborhood.
Can I ask you a question? Pastor Boyd, let me just ask you, one of the things that characterizes your work and Cheryl's work in Mecklenburg County is that there are many faith-based communities of many kinds, and you really are creating a kind of multi community, multi-faith-based effort to tackle some of these problems. Could you talk a little bit about how that works, what the kinds of relationships you're building and how it plays out in the different communities?
So for me, again, it always goes back to relationships. and our need to understand and agree with our goal, the end goal, because I think if we can agree on an end goal, it will allow us to get past our differences. And so that then allows for, in the faith-based vernacular, multi-denominationalism, where we are not divided on the differences of our doctrine, but united on the end goal. And so our end goal here was to make a difference in our congregations. And when we say congregations, that term is universal, not just to represent our individual congregations, but our congregations, which also include our communities. And that is, with this coalition, Aetna has recognized that with the partnership of public health, in which governments are pretty tacit sometimes in their unwillingness to partner directly with faith-based organizations. They will do with nonprofits or CDCs, but not with faith-based. This is a unique partnership in that the government has partnered with faith-based organizations, where we started off, I think, with 7 churches, and now up to 60, along with the Novat Hospital in Charlotte, American Heart Association, the YMCA, UNCC, Johnson C. Smith. So this coalition of partners are working and have had tremendous success on driving the needle on chronic diseases, those diseases that impact African Americans and people of color most: hypertension, diabetes, and heart disease, which can be affected through, which is, from a faith-based perspective, the most difficult to change is behavior. Even when we want to change, it's difficult. But when you have the right kind of support and competition breeds a kind of energy and excitement and participation that, even in my knowing that I need to get up and walk, does not for me. So the coalition, the building of the coalition that has come together around this, and being able to put together resources. Cheryl's the brain trust behind this, and it has brought together a kind of partnership that no one saw or thought possible.
For that, is the microphone.
Hey, good afternoon, everybody. My name is Ade Eladakun. I'm here representing Women Heart. We're a non-profit, but we work with women who have heart disease issues. So I want to ask Reverend Boyd, do you think the potential for utilizing churches as a way to reach minority populations of people, do you think that is a template that could be implemented on a larger, in other states as well? Okay.
Yes. So I think the question is, could faith-based, the template of using faith-based organizations as a way in which an avenue for addressing women's heart health issues?
Yes.
Is that absolutely?
Yes.
As long as the initiators understand that it's about building the relationship, not about the relationship with the building, but going through the pastor who has a need to embrace legitimate opportunities for trying to address situations that have adversely affected people in our congregations. Now, keep in mind, we too are gatekeepers of our congregation, because people have poached from our people and our congregations so often and for so long, and oftentimes pastors has been used as a ploy and continue to be used as a ploy, as validation for things that governments want to do, to say the church has tacitly approved this and laid hands on it, so it must be okay. When in fact that has not been the case. And so we're even careful about showing up at certain events, because the next time we look up, our name is attached as a branding to something that we had no idea was even taking place. So you have to build the relationship. You have to spend time with the pastor. You have to be open and forthright about what your intentions are, and be willing to show the links at which you are committed to seeing it through, if you're asking that church or denomination to partner with you, because a lot is at stake.
I was thinking about that you mentioned public, so that's what made me think of this. The importance of us at this moment, because for the APHA, for National Public Health Week, to start with grassroots for Public Health Week says a lot. And because public implies something different from grassroots, right? So thinking about how we can, the challenges that you've had working with government or with the public part of public health, and what kind of wisdom could we provide for our audience, or what kind of things, what would be liberatory, right? How could we use grassroots at this moment for public health? And what advice would you give, or what are some lessons, or what are the challenges? I would say, Javier, I'm going to bug you. Come on, what you got?
So I'm going to think through how Dr. Perry, gave an example of how positioning grassroots organizations to be the primary, or small organizations to be the primary recipient of funding is the way to go. And what I mean by that is no public health public institution should receive all the funding from the CDC or HHS or anything like that, because what it does is it puts all of us on this panel in that role that the pastor just recognized as co-signing and saying, like, this initiative makes sense. We got $50,000. We can barely do what we can with this, but the majority of the money sits there. So all of you in the audience who ends up working at a public health institution in your state or your county or in your city, push back against the BS where it's like we got to be the lead organization. That would help tremendously the grassroots not-for-profit groups, not the not-for-profit industrial complexes that are big. You'll see them right away. I'm not going to name them because they exist, but they exist. But the ones that are there in your neighborhood doing the work are the epidemiologists of the neighborhood, of the street. Like, those are the folks to fund. So that's how you can help coming out of your programs and coming out of these conferences. Like, we're not going to be the lead recipient. Flint Neighborhood and United is going to be the lead. That's a help. On the other side, from the grassroots side, is also saying you can't be everything too. Like, I'm in the process right now working with my initiative, working with the Red Hook Initiative, and understanding, like, what are we great at? We're great at youth development work that has an impact on families. Okay, stop, right? Like, we can't do everything in that neighborhood because we're chasing that money. We're chasing the funding. So, like, we're mission veering and mission creeping and all that. So if there was an agreement that we can stay focused on eradicating a certain public health initiative area of focus in a neighborhood, public health department, you got to roll, academic institution, you got to roll, grassroots, not-for-profit, we're the lead. That would be a game changer. For all the big cities specifically that have more resources coming in, for the smaller folks, I got a good education on how hard that is, because you're really scrambling against everyone, but still, like, trying to get that agreement between academia, public health institutions, and grassroots, that will go a long way of changing the power dynamics that were explained by Dr. Perry earlier.
If I can ask one other thing. Cheryl, did you want to add something?
You understand that you have to take the risk. And I think that's been unique with Village Heartbeat, is that the village is about us taking care of one another. That BEAT stands for something. It's the building the education accountability together. So I've been working in a system that sometimes I can see being as an agitator, because I'm teaching them what the loopholes are. So when you look at the model, there's two overarching pieces. One is something about competition that challenges us and motivates us. So that's the piece that took off. But the other piece has been the bold part. That's the building, the opportunity, the leadership, and the development. Every public health system, every county moves money because we're taxpayers. So once I began to understand what the system was, we're now teaching them how to come in that procurement process. But I had to leave from where I am because those of us that work in the system, we've been trained with the knowledge. But what we don't do enough is teach that knowledge back to our communities. And it has to be more of us. And I tell them what I love about faith, being with the pastors, is my own personal faith, but also understand risk comes and you have to pray that if you go to work and systems see all of these faith-based. Last week we had a training with government because some of them were easy to get into the system, and now it's a little bit tricky how they're getting into it. Different questions, a new system. So we requested for a whole training just for our constituents, because I've said now that we've won the money, you're going to see many more of them coming in because they're entitled to being a part of the flat platform. But that's the challenge that I think those of us that's been trained in public health, we have to do a better job leading from inside to outside of communities. Thank you.
What was it? Your question? Yeah, I just wanted the risk part. So we spend a lot of energy reframing how we talk about risk, because for me, it's riskier for you to not value community. So when I'm investing in an organization, because I have a weird life where sometimes I'm a grantor, right? I sit on boards and I'm giving out money. And in that space, I can hear how we talk about grassroots organizations and, oh, it's risky. It's risky. You should be more worried that you're about to spend these millions of dollars and you will have no actual change in the community. So that should be your first risk flag, not if they have a mission and vision statement and they've had 3 years of financials. Anyway, go ahead, sorry.
Question for you. Lindsay Mason, thank you so much for this panel. I'm very curious just because I commend Aetna for being really a pioneer in really convening, but I heard the Kellogg Foundation, I've heard Robert Wood Johnson. How do you see philanthropy playing a role in this public-private partnership to really advance that change and really drive some of the impact on the local level? Yeah, I'll pause there. I have a lot of questions, but I think that this is very fascinating.
Okay. In Flint, we have CS Mott Foundation. They're funding me in order to get the message out to people. They, not just them, but we also have Ruth Mott Foundation, Hagerman Foundation, Kellogg Foundation is in Flint. Well, they have some funding in Flint. And a lot of them, you will find that within their organizations, the ones at Community Foundation also, they have residents, grassroots residents that's in there doing work, pushing for change, making things happen. I'm so proud. I'm so proud of what is happening in the city, all over the city. We have the Michigan School for the Deaf, for instance. We have the largest population of hearing impaired people in our city. And when the water crisis first hit, they knew nothing about it until some of the people that work in the nonprofits and for the funders reached out to them, reached out to some of the translators in order to get the message to them. And it made a world of difference. We also have a large Hispanic population. Same thing with them. They were too afraid to go for the services that they need. They wouldn't even go get bottled water when they need it. So we had someone that reached out to someone that spoke fluent Spanish to start working at these water locations so that they would be able to communicate with their people. So philanthropy in Flint, I was asked to sit on a board of Community Foundation. And it was done so that our voice would be heard. And it's not just me, but there's other residents that's doing the same thing.
First, we're almost at time, but there's a book by a brother named Edgar Villanueva. I
That's
think.
my godfather's
There we
son.
go.
Some random craziness right there. It's a great book.
So in my mind, when he and I hang out, I've met him twice, but in my mind we're friends. Like Ibram, I've met him 3 times, but he's like my best friend. Yeah. So it's called Decolonized Philanthropy, and it really has a whole framework around what this could look like. The beauty of working inside this space, there's 3 prongs, government, philanthropy, and private community. Like, how do we make all 3 work better? It's really what I try to spend my life and existence doing. And so, yes, there is a move for that.
Well, we are very close to time, and I just want to thank all of the panelists for all of their insights, and this has just been an incredible conversation. It's really been a privilege for me to be part of it. There are so many things we haven't discussed. There's so many issues relating to youth and multi-generational challenges that we face, poverty. I mean, you name it. There's a lot we could talk about. But I just want to thank the panelists, ask if there are any last comments you'd like to make.
I just want to for everybody who pays attention to social media, specifically, Black Twitter or people of color, just look at the brother Nipsey Russell who was shot and killed yesterday. It's really important for people in the room and people online to understand the impact that people are feeling right now, especially people of color, especially, the African American community. What the brother was trying to do out in Los Angeles by, investing in co-working space and investing in STEM education. When you talk about the social determinants of health, you talk about the drivers of what happens, that he was pushing against the drivers in that neighborhood. So like whoever picks up the movement that was starting as a leader in the music industry, but also as a Black man, I think it's important for everybody in the room and everybody online to just take a moment of pause and think about that, because there are young people in your neighborhood who are going to be feeling like, lost and feeling like somebody from their generation is gone, was taken from them, and he was trying to educate them on multiple levels. So I leave with that, because I think it's social media was brought up before about how harmful it is as it relates to redlining, but this is also a moment of like showing, especially those who consider themselves allies in the room or online, to understand some of the people that are lost to the Black community that we're trying to really empower and move the narrative and the conversation in a positive direction.
Deborah?
So I want to thank everybody for joining us today. I want you to encourage your brothers and sisters who are out there in the fight and the struggles in the community, to encourage them never to give up. I mean, our project was a 3-year struggle, but every day when we walk into that market, it just, it's amazing the lives that we're going to change. So I was thinking about what you said, Doctor, about you got to worry about, what you're going to do. So we don't worry about that, because we're doing it already. We're changing laws because we're going to make life better for everybody there. But I want everybody to stay encouraged, and we appreciate the time and effort everybody put into this program today.
Thank you very much. And Pastor Boyd?
We remain encouraged. We work really hard to keep our young people encouraged. I oftentimes say that many of the successes of people of color, especially African Americans, were achieved during a generation in time where they had far less, but did far more. The scriptures talk about each generation growing weaker, while at the same time becoming wiser. I think we have become wiser in many ways, but weaker in many ways. And part of that is our missing the mark in valuing the component of faith. Your ability to believe that you can, whether or you can't, is true, whichever one you choose. And so we believe that you can, in spite of where you live, or whether you have an address, or whether you took a shower the day before you went to school. We believe you can learn. We believe you can succeed. We believe you will succeed. We believe that we will overcome many of the challenges that continue to pop up, and the struggle makes us stronger. And I'm grateful to be here today with all of you. Thank you.
Thank you. Karma, last word.
Thank you for having me here. I do appreciate it. And my last words is I would like to tell everyone, be nosy. Find out what's going on. It's your community. It's yours. It belongs to you. Act like it.
All right. Thank you all.
Some of the things we learned today. I think that you're right. Policy, big P and little p, is critical in all of this discussion. And we know communities know their needs best, and we in the public health community must learn to do a better job of following. We're at the beginning of a time of change, but we're also several generations of actually seeing this change come to fruition, which means we are in a lifelong fight. And we have to take this battle to address social determinants of health, the misrepresentation of truth, and the racism that exists in our policies, programs, and with us as individuals, in our government, in our healthcare systems, and yes, among those of us in the public health community. And we need to do all we can to take this, to understand it, to address the health disparities and inequities that exist in our communities. I want to thank you again to the Aetna Foundation for their support. I want to thank our panelists. I think this was an outstanding and fascinating conversation. So thank you, Pastor Boyd, Karma, Javi, Debbie, our moderator, Steve, Dr. Claire Perry, Dr. Pam Altonen, and thank you to all of you who came today, to those of you who are participating via the live web stream. I think that we've begun the conversation, and there's much more that we can do. Now go out there, recognize your own implicit biases, address people as people, and help our communities thrive. We have food outside, so please join us in a reception, continue the conversation, start those relationships, start creating communities across communities, and again, thank you all very, very much. It was an outstanding, outstanding start to our National Public Health Week.
Dr. George is back there.